very good afternoon to all of you. I welcome you today to our webinar on thrombophilia and stroke. My name is Dr. Preeti and I work with the Global Reference Lab of Metropolis here at Mumbai. I basically handle day-to-day hematology. The question and answer session will be at the end of the webinar. You can also ask your questions in the chat box. And it gives me immense pleasure to introduce our eminent speaker, Dr. Amit Kulkarni. Dr. Kulkarni is a DM in neurology. He has done that from GB Pant Hospital, New Delhi. He has done his fellowship in stroke and neurosomnology from NUH Singapore. Currently, he is working as a senior consultant and lead with neurology and stroke department of Sparsh Hospitals in Bangalore. He has more than 15 publications in national and international journals. Sir holds a lot of propositions as the Honorable Secretary, Bangalore Stroke Support Group. He is the founder trustee of the Karnataka Stroke Foundation, and he is also a EC member of the Society of Neurosomnology India. Respected sir, I hand it over to you to start your presentation on the thrombophilia management and clinical aspects.
All the delegates and all my colleagues, dear friends, and colleagues here to this symposium or this webinar. And I would be speaking on thrombophilia and stroke. And since I'm a clinician, I think I'll touch upon some of the relevant things as far as the diagnostic aspects as well as the treatment aspects are concerned. Just to make this a little more interesting, I would like to start it with a case presentation. We had a 30-year-old with no comorbidities, that means non-diabetic, non-hypertensive. He was an occasional smoker, occasional alcohol intake with no recent binge, presented to the emergency room with sudden onset left hemiplegia, altered sensorium, and gaze preference to the left, with left hemi-neglect, which means that this is a large vessel occlusion. This is of 4.5 hours duration. So the patient was just coming out of the IV window. So this patient, as per protocol, was shifted to the cath lab for DSA followed by mechanical thrombectomy. So as we can see here, you can see the preliminary angiogram, the DSA which was done, and you can see this MCA, the M1 portion of the MCA is cut off. So it's a large vessel occlusion. And so whenever there's a large vessel occlusion, what has to be done is a primary mechanical thrombectomy. And so it was done in this case with a stent retriever, which with that, we could achieve TK3 recanalization. You can see that the artery is filling up well. So this is the clot. It's a very tiny little clot, but this tiny little clot caused a lot of havoc. So clot extraction was done. So this patient had a homocysteine which was mildly elevated. He had a lupus anticoagulant positive. His anticardiolipin was negative. Beta-2 glycoprotein was negative. His 2D echo was normal. 24 hours Holter was normal. So he was started on low molecular weight heparin and single antiplatelet post procedure, and we switched him over to acetrom with dose titration. After that, walked with minimal support. Left upper limb power improved, even post procedure immediately the power improved, and at the time of discharge his left upper limb power was 3/5 and left lower limb power was 4 to 4+/5. So what do we do next? So probably I think my slides further on should be able to answer that question, and if there's any doubt, I think we can take those questions at the end of it. So this patient, we started him on acetrom, and then we dose titrated to maintain the INR in the therapeutic range. We'll see some of these things where the controversies and what we need to do and how relevant it is. This is another case, an acute onset of right-sided weakness with aphasia. The presentation to the hospital was at 48 hours, which means the patient was outside the window period. So you can see that this was a hypertense MCA with the left MCA cut off. This patient had a carotid thrombus on the CT angio, which was a neck angio. And a Doppler was done, which shows, you can see this is a free floating thrombus. You can see that there's a flow on Doppler all around. And this is the filling defect that you can see there. So this was a patient with free floating thrombus, a chunk of which went into the brain and caused a MCA occlusion. The patient was outside the window period, so there was no question about doing any either a thrombectomy or IV TPA. So the options were in front of us: tried and tested anticoagulation and wait versus early endarterectomy. There was selected case series, and there are no RCTs available for this. However, we did the TCD, which is a transcranial Doppler, where we measure the MCA signals in both the temples. And this patient had a positive microembolic signals on transcranial Doppler monitoring, which means that the lesion in the neck was actively embolizing, which meant that this is a high risk lesion. So in this patient, again, the pros and cons were discussed with the family. We told them that anticoagulation can be done. We can still wait and watch. The family was in favor of emergent endarterectomy. So the patient was taken up for endarterectomy, and following which the deficits remained the same, and gradually at the end of 1 week he started improving. So further on, so this same patient earlier had one more arterial emboli. He had an ulnar artery thrombosis earlier, and on evaluation he was found to have a protein S deficiency, and this protein S deficiency was subsequently confirmed after stopping the medications after 3 months. So the question now is, what medical treatment should be next? And I think, as I told you, these are the two case scenarios which should make us think as to what we should do further for such a patient. So as this patient falls under stroke of other determined etiology, most likely, because there may be other things as well which are probably not detected or we don't know about. So what are these inherited and non-inherited conditions with associated with hypercoagulable states? So as we know, inherited conditions are protein S deficiency, protein C deficiency, antithrombin 3, factor V Leiden, which is the most common, prothrombin gene mutation, increased homocysteine levels, increased fibrinogen levels, increased lipoprotein little a. The non-inherited conditions, and these are very important, are antiphospholipid syndrome. Then you have the conditions like cancer, which is causing a Trousseau syndrome. Increased lipoprotein little a is also a feature here, and other myeloproliferative disorders where the platelets may be very high, which may be leading to a hypercoagulable state. So these are the cutoff ranges, and I think the hematology expert on the panel will talk about this in fair detail. So regarding thrombophilia and stroke, so we all know that the coagulation abnormalities do predispose to recurrent venous thrombosis. So there is very little confusion or doubt regarding this. However, the relevance of coagulation abnormalities in ischemic arterial stroke is uncertain. So we are not very sure about this because there's not much of data on this. Coagulation abnormalities almost contribute to 4 to 5% of stroke burden. This is according to Shamal Kumar Das et al. Study. And in pediatric stroke, this figure is a little higher, which is about 8%. So the deficiencies of natural anticoagulants, antithrombin, protein C, and protein S. So these deficiencies were among the first which were established hereditary thrombophilias. For antithrombin protein C, there were different deficiencies which were noted, like type 1, type 2 deficiencies. I'll not go into the details of this. But what is important to understand is the homozygous antithrombin deficiency. Although it is rare, it is more common, or it's a bigger risk factor for recurrent or venous thrombosis. Same way, homozygous protein C and protein S deficiencies are also very rare, but when present, they are definitely a higher risk for recurrent venous thrombosis. So this was a study which was done in India. So this data was taken for patients aged between 16 to 45 years, and the study was conducted over 20 months. And we can see here that in this study, we saw that hyperhomocysteinemia was probably the highest, the risk factor. And that was in this study more commonly seen in men. And again, as compared to when we looked at the thrombotic event in the presence of thrombophilia, we saw that hyperhomocysteinemia was definitely something which was the highest in this category. This was followed by Apla syndrome, and this was followed by the various other inherited thrombophilias. So a limited number of studies have investigated protein C or protein C deficiencies in relation to ischemic strokes. Various studies have not shown a significant role. There was one more larger case control study which showed there was no significant association between arterial ischemic stroke and protein C deficiency. However, in children, there is a slightly higher degree of evidence to show that ischemic stroke is definitely one of the things which is because of these inherited thrombophilias, more so in the homozygous state. So protein C, protein S antithrombin deficiencies definitely predisposed to venous strokes. However, there is no significant association. However, there are case reports which show a slightly increased risk of arterial stroke in such patients. So factor V Leiden is the most common hereditary thrombophilia, and the prevalence is 20 to 25% in unselected consecutive patients with venous thromboembolism. The prevalence in the general population varies considerably, and factor V Leiden is actually much rare amongst Asians and Africans, and more common in the Caucasians and the white population. So factor V Leiden was strongly associated with stroke, and in this study which was done in US, this study showed that factor V Leiden is associated with ischemic stroke in young adults. So there was a strong suspicion and there was a strong evidence to suggest that factor V Leiden was responsible for arterial ischemic strokes. So but however, there are other studies which have not shown the same. So it is still debatable whether this FVL mutation is also associated with occurrence of arterial thrombosis. And as I said, this is still a controversial area where the final word has not been said. But after all these studies, one can say one thing, that the risk with these conditions for arterial ischemic strokes, if at all, it's very small. So this risk definitely is a little higher when it comes to children. And the same applies with prothrombin gene mutation as well. So in unselected patients with VT, the presence of prothrombin gene mutation is approximately 6%. And again, all these studies have shown that they did not demonstrate a direct relationship with arterial ischemic strokes. However, there are some small studies which have shown a slightly higher risk. So inherited thrombophilias are associated with the increased risk of ischemic strokes in adults, particularly young adults, although this risk is not as high as venous strokes. The association of factor V Leiden and prothrombin gene mutation was definitely stronger in homozygous than in heterozygous state. This is what I was referring to, suggesting a potential dose-response relationship and a definite causal role for thrombophilia. So when we have a factor V Leiden or a prothrombin gene mutation, the risk was higher, or it was stronger when the mutation was homozygous. This is another condition where there's increased levels of factor VIII, so which is also responsible for thrombophilias. There are other factors which may be associated with high factor VIII levels, which may be increased age itself, high body mass index, diabetes, and hypertriglyceridemia. We must remember this. And it can also be a part of acute phase reactants. So please do not take this in isolation. And in most of these conditions, there's also a concomitant increase in factor VIII as well as 1 millibrand factor levels. So the very clear dose-dependent relationship between factor VIII levels and the risk of VTE is there. However, we must consider the other reports, look at these false positive results when we are interpreting it, and we have to interpret it with caution. Now, coming to a more established, indications. So hyperhomocysteinemia is an intermediate in the metabolism of amino acids. Methionine and cysteine participate in several metabolic pathways. So some of the enzymes in homocysteine metabolism are dependent on like vitamin B12, B6, and folic acid. And this is what we supplement whenever somebody has hyperhomocysteinemia. So again, in this condition also, homozygosity for this polymorphism, for this mutation, leads to a 24% increased risk of homocysteine levels, which leads to hyperhomocysteinemia. And hyperhomocysteinemia was associated with a 2.5-fold increase of first venous thromboembolism. And association with homocysteine levels was stronger in men than in women, and it increased with age. So the commonest thrombophilia in both arterial and venous thrombotic strokes was hyperhomocysteinemia. However, in various studies, it's not been proven that while correcting those risk factors, like by supplementing the vitamin B12, B6, it has not been shown that it will correct the underlying thrombophilia. So a meta-analysis of 12 prospective, 18 retrospective studies shows a 25% lower total homocysteine concentration was associated with a significantly lower risk of stroke. And in conclusion, hyperhomocysteinemia definitely predisposes to both arterial and venous strokes. So, evidence for arterial strokes, most case control studies have failed to demonstrate a direct relationship. Meta-analysis have demonstrated a significant correlation between homocysteine and the risk of arterial thrombosis. When it comes to APLA, again, here, this is a very strong risk factor. Again, a risk factor for both arterial as well as venous strokes, and definitely good risk factor for arterial strokes. We can see that the manifestations of APS, 19.8% of these patients presented with stroke and 11% presented with TIA. So this APS stroke is one of the very common manifestations of APS. So what are the criteria for APLA? Vascular thrombosis, one or more episodes of arterial, venous, or small vessel thrombosis. Pregnancy morbidities, including 3 or more otherwise unexplained recurrent abortions before 10 weeks of gestation. Also, 1 or more fetal losses after the 10th week of gestation. So 3 or more before 10 weeks, 1 or more fetal losses after 10 weeks. Any stillbirths, episodes of preeclampsia, preterm labor, and all these conditions are the criteria. When it comes to lab, basically anticardiolipin or anti-beta-2 glycoprotein, IgG or IgM, it should be present in medium or high titer, very important. Medium or high titer, it should be there on 2 or more occasions, at least 3 months apart. So it's very important that once we test it, we need to test it again after 12 weeks and ensure that we stop the low molecular weight heparin or the acetrom or warfarin, which has been continuing for at least a week or 10 days. So lupus anticoagulant in plasma on 2 or more occasions. So when it comes to LAC, that is lupus anticoagulant, it should just be present. It need not be in a high titer on 2 or more occasions, again 3 months apart. So it's very important that this 2 times it is tested. So definite APS is considered to be present. At least one of the clinical criteria and one of the lab criteria is met. So either one of this lab criteria can be there and one of the clinical criteria can be there. So accumulated evidence from these trials with APS and thrombosis, we know that we should treat with warfarin for the long term, and we should maintain a therapeutic INR of between 2 to 3. And in patients with arterial thrombosis, they may require a higher degree of anticoagulation, where we may try to maintain the INR a little higher. So probably in this patients, we may try to maintain them between 2.5 to 3.5. But however, this is a little controversial. So this I already told. So patients with definite APS, we recommend prolonged warfarin therapy, INR of 2 to 3 in these patients with first venous strokes. And in those people with recurrent events or arterial events, we try to maintain it around 3. So it's probably around 2.5 to 3.5, maintain it above, a little above 3 as much as possible. So there are other acquired conditions which can cause a false positive thrombophilia results. So these are all the various conditions which can cause it. So when thrombophilia is performed, what is the things that we need to look at? So do not perform thrombophilia testing at the time of thrombosis diagnosis or during the initial 3 months course of anticoagulation. So what happens is, you please ensure when the patient comes to the emergency and you're going to start them on anticoagulation, please take the sample before this anticoagulation is started. So that sample is very important. However, you have to take that with a pinch of salt, because protein C, protein S, antithrombin, all these levels may be actually falsely low during the acute thrombotic episode. So such a thing has to be reconfirmed when it is found to be low in the initial period. And retesting that it becomes very important. So when testing for thrombophilias following venous thrombosis, use either a 2-stage testing approach or perform a testing after a minimum of 3 months of anticoagulant therapy. So there are other conditions like pregnancy, sex, estrogen use. They reduce the level of protein S, and they can be falsely implicated. And the use of and during pregnancy or when somebody is on estrogen, these are times where you generally tend to avoid the testing. So screening of stroke patients for coagulopathies, when patients with stroke in whom the yield of screening is likely to be highest are those patients who are young, who are less than 50 years of age, those who have experienced repeated unexplained strokes, those with a prior history of thrombosis, particularly prior history of DVT or venous pulmonary thromboembolism, patients with unexplained cerebral venous thrombosis, that means unprovoked cerebral venous thrombosis. So these are all the patients where the yield is likely to be higher. So whenever we are investigating for cryptogenic strokes, this is one condition which we must very carefully look for. Apart from thrombophilias, this is one condition where you can have occult malignancy, and more so when somebody has got an elevated D-dimer levels. So these are the common sites like lump, lymphoma, hepatobiliary, and gastrointestinal tract. So these are all the malignancies which can cause cryptogenic strokes. So sometimes they can be also there, and they can be very easily missed. So these are all the indications for venous thrombophilia screening. So idiopathic venous thromboembolism less than 50 years, young patients with arterial ischemia caused by paradoxical embolism, venous thromboembolism in unusual sites, women with venous thromboembolism during pregnancy or puerperium, women with VTE during use of oral contraceptives or hormone replacements, women with VTE before prescribing hormonal replacements, women with multiple inexplicable pregnancy losses, young women with a strongly positive family history, and first venous thromboembolism and a positive family history. So these are all things where you would like to do a thrombophilia testing. So there are various mechanisms of cryptogenic stroke. The most important thing is something like a hidden or an occult AF. Aortic thrombotic disease may be one of them, and PFO. So PFO has gained a lot of attention of late because of the device closure and other trials which have come positive. So undefined thrombophilias related to antiphospholipids or occult cancer are the things which we must look for in cryptogenic strokes. So how do you, firstly, you have to look for a PFO or a right to left shunt. So the best two ways of doing it is by doing a TEE or a transesophageal echo. Equally good or probably a little more sensitive is the transcranial Doppler bubble test by using agitated saline. And this can help in identifying a patent right to left shunt, in other words, a PFO. And this PFO is, if it is large enough, is probably one of the reasons to cause paradoxical embolism. So in those people who have got a large PFO and who have got one or more ischemic strokes, so in these patients, we must do a thrombophilia testing. And in these patients, we must do a factor V Leiden, prothrombin gene mutation, and all protein S, protein C antithrombin deficiencies. Since these are the factors which will lead to DVT, and this is the clot which will travel upstairs, cross the PFO, go from the right to the left. So that's why we call it a right to left shunt, and cause a paradoxical embolism. So this is a busy slide, but I think most of this I have already covered in what I have spoken. CVT is not so controversial when it comes to these thrombophilias. So I'll just dwell a few moments on CVT also. So initial anticoagulation with low molecular weight heparin is followed by longer term anticoagulation to prevent further venous thrombotic events. The risk of recurrent CVT is about 2 to 7%, and the risk of other venous thrombosis about 4 to 7% per year. So now this is one controversial area where, how long do we treat these patients with CVT? So if somebody has presented with a provoking factor, patient has one episode of CVT and some transient risk factors like oral contraceptive usage, or the patient is extremely dehydrated, or some infections, some trauma, or some recent surgical interventions. So when there's a provoking factor with one episode of CVT, generally we would like to correct that provoking factor, and we give a short-term anticoagulation for 3 to 6 months. So when we have a patient with one episode of CVT of unknown cause, so we don't know from where this patient has had a thrombosis. So in these patients, it's wise to continue anticoagulation for about 6 to 12 months. But when we have patients with 2 or more CVTs, that means recurrent CVTs, or if somebody has got one episode and one severe prothrombotic risk. So these are the patients where we recommend indefinite or lifelong anticoagulation. So is there a role for NOACs in CVT? Well, Respect CVT study, which it showed us that it is reasonably safe. And in this, there were 120 patients who were enrolled, and there were no recurrent venous thromboembolic events. They were almost comparable between the two groups. While major bleeding occurred actually in 2 with warfarin and in 1 patient with dabigatran. However, still the last word has not been said. Still, it's not in the guidelines. So, but still we know that DOACs are definitely safer, since they definitely cause a lesser risk of intracranial bleeding. So, but yet it has to come in the guidelines. There are more studies which are awaited, more studies in the pipeline, which are going to show us that. So I spoke about mild and severe thrombophilia. So what are these mild and what are these severe ones? So because as we know, if it's a severe thrombophilia, we are going to treat these patients with lifelong anticoagulation or indefinite anticoagulation. So what are the ones which are mild? So heterozygous factor V Leiden, prothrombin gene mutation, or elevated factor VII. So these are having actually a lower risk of recurrence at 7% at 2 years, and 11% at 5 years. These are considered as mild. Even hyperhomocysteinemia actually is considered as a mild risk as compared to when you look at the mild versus severe. So when you look at the severe ones, so you have homozygous prothrombin mutation, homozygous factor V Leiden, and these deficiencies of protein C, protein S, and antithrombin. Or when we have combined thrombophilias, multiple thrombophilias, and antiphospholipid syndrome. Any antiphospholipid syndrome is always categorized as severe. So annual incidence and risk of recurrence is increased markedly in those with combined thrombophilic defects, especially those who have double heterozygous. That means they are heterozygous for factor V Leiden and they are heterozygous for say a protein S deficiency or for prothrombin deficiency. So those are also at a higher risk factor. Of course, we know that homozygous ones are at higher risk factor and they are classified as severe. So this I already spoke about. So the severe ones are the ones where we tend to continue their anticoagulation for an indefinite period or for a longer duration, or in those people who don't have a provoked CVT or recurrent CVTs with one of these tests being positive. So indefinite anticoagulation in recurrent CVT, venous thromboembolism after CVT, that means two separate events, and first CVT with all these severe thrombophilias. In these conditions, we do an indefinite anticoagulation and target INR being 2 to 3. So one thing here we must try to remember is that in patients who have APLA or secondary APLA, when they have SLE or other connective tissue disorders, in those patients, definitely NOACs or DOACs should not be considered. And in those people, the best choice would still be acetrom, that is acinocumarol or warfarin itself. And as I told you, the target INR as was discussed earlier. So these are the different messages I would like to give. So inherited coagulation disorders are recognized risk factors for recurrent venous thrombosis. Effect of arterial ischemic stroke, if at all present, is only modest. So screening of all patients of stroke for coagulation disorders is not warranted. Inherited thrombophilia patients developing arterial strokes also need an independent evaluation, need an evaluation for other independent causes. Please remember this one thing. So if you just find that protein C is low once and the patient has one arterial stroke, do not assume that that is responsible for the arterial ischemic stroke. And we must do all the tests which are necessary to come to that conclusion. Even in patients with thrombophilia with increased risk of venous stroke, duration of anticoagulation should be individualized. And current guidelines are mainly based on expert consensus. So we are not sure, these data are not large data. So we cannot be 100% sure that all these things, that whatever we are talking about, these are on a case-to-case basis and may have to be modified on a case-to-case basis. The risk of bleeding and chance of recurrence has to be carefully looked at. So the Hasbled score also has to be looked and kept in mind when we are prescribing anticoagulation. In patients with cryptogenic ischemic stroke or TIA, who do not fulfill the criteria for antiphospholipid syndrome but have positive antiphospholipid antibodies. For example, somebody has got presented with an arterial ischemic stroke, has got, once we have tested and antiphospholipid antibody is positive. So in this patient, there is a controversy. Some people would like to start anticoagulation and then repeat it. And if the second time it is negative, tend to stop anticoagulation, while some people would tend to prefer antiplatelet therapy here. And for patients with otherwise cryptogenic strokes or recurrent cryptogenic strokes who meet full criteria for APS, in these patients, there is very little doubt that there is long-term anticoagulation, which is preferred. So inherited thrombophilias are thought to be rare causes of ischemic stroke in adults. For patients with ischemic stroke or TIA who have established inherited thrombophilias, the presence of DVT is an indication for long-term anticoagulation. In addition, anticoagulation may be reasonable for patients with an inherited thrombophilia who have recurrent strokes. So for example, somebody who has got recurrent strokes. So in our patient, when I answered this, I showed you the second case. The patient had recurrent ischemic events. The patient was tested positive for protein C, protein S, and tested twice. So in this patient, the answer is definite lifelong anticoagulation. And our first patient whom we saw recently, where the lupus anticoagulant was positive the first time around, what I have done is started him on anticoagulation for 3 months, and I'll stop the anticoagulation for about a week or so, and I'll repeat the lupus anticoagulant test. And at that time also it's positive. That I am inclined to continue his anticoagulation for indefinite period or lifelong. And in case he tests negative after 3 months, then I assume it is possibly false positive the first time around. In that case, I would probably just continue him on antiplatelets. So in the absence of venous thrombosis or recurrent strokes, either anticoagulation or antiplatelet therapy is considered reasonable. So somebody who presents with one stroke, it's not recurrent, there's no history of venous thrombosis, you may consider either antiplatelet or anticoagulation, here depending upon the risk that you can ascertain. So with this presentation, I would like to thank all of you for patient hearing, and once again thank Metropolis Labs for giving me this opportunity to present on this forum. And thank you one and all.
That was a very enlightening presentation, and it's a vast topic, I feel, but I think that you have covered all of it very beautifully. Sir, there are a few questions, but I think we will be taking it at the end of the session. The audience, if you want to ask any more questions, you can write your questions in the chat box provided. So I'll be taking the diagnostic aspect, covering the diagnostic aspects of thrombophilia, the aim of testing for thrombophilia, who should be tested, when they should be tested, and which test should be done, and the variables which affect all these phenotypic assays. Most of this has been covered by Dr. Kulkarni. I'll just give a quick recap of all of this. So thrombophilia or hypercoagulability is defined as a tendency to develop thrombosis due to predisposing hereditary or acquired risk factors. The inherited thrombophilic disorders predispose young patients for various venous or arterial thrombotic and thromboembolic episodes. So we know the virtuous triad, which has stasis, vessel wall injury, and hypocoagulability, and these three leading to thrombosis. This is the coagulation cascade with the intrinsic and the extrinsic pathways. So the coagulation cascade, as we all know, is made of procoagulants and anticoagulants. So the anticoagulants here are all activated protein C, then protein S, antithrombin. And here is a flowchart which actually shows that how increased procoagulants or decreased anticoagulants can lead to thrombus formation. The inherited causes of thrombophilia are either gain in function or increase in procoagulants. So the most common that we see over here is factor 5 leading mutation or the prothrombin mutation G20210A, APLAS, factor 8, hyperhomocysteinemia or dysfibrinogenemia. Inherited causes also include loss in function, decreased or deficiency of anticoagulants, which I earlier mentioned, protein C, protein S, and antithrombin 3. There was this meta-analysis that was done and it was published in the Journal of American Heart Association. They basically did a meta-analysis by including 68 eligible studies, which collectively enrolled approximately around there is one figure missing over there, but it was approximately around 119,160 stroke patients and 96,057 controls. And the conclusion of the meta-analysis was that some of the inherited thrombophilias, like most commonly factor 5 lead-in, which Sir has covered earlier, and prothrombin mutation, protein C and S, are associated with increased risk of arterial ischemic stroke in adults. So this was from the study itself. This is a forest plot which again shows the odds ratio with the factor 5 lead-in and other inherited mutations, and it shows a significant association with factor 5 lead-in, protein C, S, and the prothrombin mutation. Acquired causes can be many: pregnancy, immobility, trauma, post-operative state, OCPs, HRT, APLA, again, malignancy, nephritic syndrome, MPNs, PNH, HIT, or chemotherapy. So what is the aim of testing? The aim of testing is to detect a well-established hereditary or acquired cause of thromboembolism, and to ensure clinically relevant testing and to avoid any misinterpretation of results. What we need to do is we need to follow the recommended guidelines of testing. Careful selection of patients should be done. The time of testing should be proper, and which assays and assay methods are used, that should be well known. Who should be tested? So adults who have confirmed VT with one of the following criteria, as Sir has already discussed, patients who have thrombosis prior to the age of 50, any predisposing risk factor, recurrent venous thrombosis, thrombosis at unusual sites like portal, mesenteric, splenic, hepatic, renal, or cerebral veins. VTE patients who have a family history of VTE can also be tested. Also, patients on vitamin K antagonist therapy, which develop skin necrosis, can also be tested for thrombophilia. Arterial thrombosis mostly is caused due to aplas, hyperhomocysteinemia, or dysfibrinogenemia. So again, these patients can be tested for thrombophilia. Pregnant women with previous VT or a positive family history of VT in the first degree relatives, or pregnant women who are suspected to have APLA. Asymptomatic first degree relatives of patients who have VT. So these asymptomatic relatives, if the first degree relative who is having a VT has a low risk, that is factor 5 lead-in or prothrombin mutation, then testing is not indicated. But with high risk factors such as antithrombin 3, PC, or protein S, testing is to be considered in selected thrombosis prone families who have more than 2 symptomatic family members. As a general rule, we should do the testing only after 6 months of an acute phase of thrombosis, or a minimum of 4 weeks after discontinuation of any anticoagulant therapy. Because as we know, the clinical management of an acute thrombotic event is not influenced by any immediate detection of any thrombophilic risk factor. And when the testing should be done, again, as I told you earlier, that we cannot do the testing in acute phase and it should be deferred for at least 6 months. But there are a few conditions in which we can do testing in the acute conditions, such as in APLA suspicion. In the pediatric group, if we are suspecting protein C or protein S deficiency, and if the patient is therapy resistant to heparin, especially in cases of antithrombin 3 deficiency. This is an algorithm for selecting patients with a first venous thromboembolism. So here the patient has had first VT. If it was provoked by strong triggers, then there is no role for testing. If it was provoked by weak triggers like just by immobility or minor trauma, or it was in a young patient who had a strong family history, or a female patient with female family members of childbearing age. In these patients, there is a role of testing, and we should do testing for factor 5 lead-in, the prothrombin gene mutation, protein S, protein C, antithrombin, and we should consider APLA testing in the cases of extensive DVT or pulmonary embolism. Unprovoked first VT, again we have to test for similar all the previous factors which I told, and we should also consider APL testing, especially in cases of arterial or recurrent events. Unusual sites like cerebral veins or splanchnic veins, again, all these tests should be done, especially for cerebral venous thrombosis. We should do test for factor 5 lead-in, PTG, protein S, protein C, antithrombin, and APLA. Splanchnic veins, we should mostly test for inherited thrombophilias, APLA, MPN, and PNH. Assays, again, the assays are divided into activity or functional assays or antigenic assays. So in activity or functional assays like protein C activity, protein S activity, and antithrombin 3 activity, there are two methodologies that are used. First is a clot-based test, or it could be a chromogenic assay. Antigenic tests are mostly immunological assays. Coming to the pre-analytical variables of sample collection and sample transportation, the sample should be collected in a citrated tube. The ratio of anticoagulant to blood should be maintained to 1:9. If it is transported at a room or ambient temperature, the analysis is preferably to be done within 4 hours of blood sampling, maximum till 24 hours. The sample is to be sent in dry ice or frozen condition if we know that the transportation time to the lab is going to take more than 4 hours. The sample is that is to be sent in such a condition has to be a fresh or frozen platelet poor plasma sample. Platelets again should be less than 10,000 per microliter. Double centrifugation is required to make such a sample, and it should be done at 2500 G for 15 minutes each. And just immediately before testing, there should be quick defrosting of the sample that was sent in a frozen condition, and homogenization of plasma should be done before testing. Coming to which test is to be performed. So APCR, the activated protein C resistance test, which again is there's also this test is also done for factor 5 lead-in as a screening test. So this is a functional assay. If it is abnormal or if it is positive, then in that scenario, we should go ahead with the DNA analysis for factor 5 lead-in mutation. So there could be two interpretations. If the APCR is either the APCR is negative, or if the APCR is positive and the DNA analysis is negative. So in that scenario, the patient might be having an acquired activated protein C resistance, which is seen in APLA. So this is the prothrombin mutation, for which only DNA analysis can be done, as the prothrombin functional assay, which it does not help in differentiating between carriers and non-carriers of this mutation. Antithrombin 3, this is again a functional assay, antithrombin 3 activity. We call it as antithrombin 3 activity in this scenario if it is reduced. So we should go ahead with the quantitative assay, that is the antithrombin 3 antigen. So in this, again, if the functional assay is abnormal or it is showing a reduced activity, it can detect both the type 1 and type 2 deficiencies of antithrombin 3, that is both the qualitative and the quantitative deficiencies. Protein C, again, this is a protein C activity, functional. It is done by functional chromogenic assay. It is reduced, and then we have to go ahead with the quantitative immunoassay. It again picks up the type 1 and type 2 deficiencies both. Protein S activity again. So this is done, this is also a chromogenic assay. If it is reduced, if the activity is reduced, we have to go ahead with the immunoassay for quantitative protein S. Picks up type 1, type 2, and type 3 protein S deficiencies. Coming to APLA. APLA, as we know that there are three major investigations, lab investigations that are done in this scenario. First is the lupus anticoagulant, second is cardiolipin antibody, and beta-2 glycoprotein 1. So in APLA, we have the screening test where we do a APTT mixing study. Then we do a DRVV screen and we do a DRVV confirm. The CLA, that is the cardiolipin antibody and beta-2 glycoprotein 1, is done by method of ELISA. And again, as we know, as Sir has also reinforced, that repeat testing, if the patient is found to be positive for any of these tests, in that scenario, repeat testing 12 weeks apart is advised. And if the repeat testing can show a false positivity in cases of some infections or due to some drugs. Factor 8, if it is more than 150%, factor 8 is an acute phase reactant, so it can be increased in any kind of an inflammation. So if it is high, we advise a repeat testing after 12 to 24 weeks for confirmation. Homocysteine, plasma level of homocysteine is done if it is on the higher side. Then, as Sir has told, the management starts. And if it is borderline, then we advise repeat testing. And DNA analysis for the MTHFR gene should not be used as a routine test to diagnose hyperhomocysteinemia. Now, all the variables that affect our assays. APCR can be false positive if there is any kind of a plasma contamination or any lupus anticoagulant interference. So what we recommend is that the sample has to be sent after double centrifugation, and because there could be an increase in phospholipid, or we can just dilute the plasma and then test. Protein C and S, these tests are again reduced in cases of anticoagulant therapy, especially by vitamin K antagonists, because both of these variables are vitamin K dependent. Antithrombin 3, this gives false high results if the patient is on VKA therapy because of compensatory increased synthesis of antithrombin 3. Now coming to this antithrombin 3, protein C and S, these can be false positive. That is, the values can be reduced if the patient has had an acute condition, and that's why we advise testing after 6 months of an acute condition. So acute thrombosis and inflammation can lead to increased consumption and reduction in all the levels, all 3 levels. And so we defer testing by 12 to 24 weeks minimum. Lupus anticoagulant, again, if the sample was not centrifuged twice, can result in a false negative result because of increased phospholipids which remain in the sample because of the platelets, hence double centrifugation is advised. Lupus anticoagulants again in acute thrombosis because of increased consumption of all the factors. It could be false negative. As I told, then we should defer testing by 12 to 24 weeks. These are the reference ranges that we use in our lab and all the methodologies that we use for testing of all the activities or the functional assay, the APCR, and the antigen assays. So as you can see, the activity are either clot-based assays or they are chromogenic assays. And the antigens we do either by alpha or immunoturbidimetry. Coming to antiphospholipid antibody syndrome. So as we know, antiphospholipid antibodies, how they act and how they lead to thrombosis. So they lead to expression of adhesion molecules and upregulation of tissue factor. They upregulate the tissue factor along with the expression of glycoprotein 2B3A. And all this leads to a thrombogenic state. And along with the interaction with coagulation, all the coagulation proteins, regulatory proteins of protein C, prothrombin and plasmin, and complement activation and other procoagulant conditions like inflammation and estrogens, all these factors combine and they lead to thrombosis. So we had the Sapporo classification, and there was this revised Sydney uh, revised Sapporo classification, which was given in Sydney in 2006. So this sir has already covered again. It has clinical criteria and the lab criteria. The clinical criteria could be vascular thrombosis or pregnancy morbidity. In vascular thrombosis, one or more clinical episodes of arterial, venous, or small vessel thrombosis in any tissue or organ. Thrombosis has to be confirmed by imaging or Doppler studies or histopathology. Pregnancy morbidity could be one or more unexplained deaths of a morphologically normal fetus at or beyond the 10th week of gestation, one or more premature births of a morphologically normal neonate before the 34th week of gestation, which could be because of eclampsia, severe preeclampsia, or recognized features of placental insufficiency. Three or more unexplained consecutive spontaneous abortions before the 10th week of gestation with maternal anatomic or hormonal abnormalities, and paternal and maternal chromosomal causes are excluded in this scenario. The lab criteria, again, the three tests are anticardiolipin antibody of IgG and or IgM isotype, which can be present in medium to high titers. Lupus anticoagulant present. Here we do the screening, the mixing study, and the confirmatory testing. Anti-beta 2 glycoprotein 1 antibody of IgG and or IgM isotype, which is again present in medium to high titers. This should be present on 2 or more occasions at least 12 weeks apart. So APS is present if at least one of the clinical and one of the lab criteria is met. And for confirmation, the testing should be performed at least 12 weeks after the clinical manifestation or after the acute episode. So the clinical scoring here, how do we choose which patient needs to go for testing? So patient selection criteria is low if the patient has a low risk of VT or arterial thromboembolism in elderly patients. These patients are at low risk of having lupus anticoagulant. And accidentally unexplained prolonged APTT and recurrent spontaneous early pregnancy loss provoke VT in young patients. These patients might have they have a moderate risk of lupus anticoagulant. And patients who have unprovoked VTE and arterial thrombosis, which is happening in young patients, thrombosis at unusual sites like cerebral and splanchnic, late pregnancy loss, thrombosis or pregnancy morbidity in patients who have autoimmune diseases. These four kind of patients are at high risk of having lupus anticoagulant. They should be screened for that. Coming to the choice of testing, sensitive APTT mixing studies that the APTT mixing study that we do over here has a particulate activator, which is silica. And that's why it's very sensitive in picking up lupus. Cephalin is the platelet substitute that we use, and Rosner's index, as we know, if it is less than 12, then the patient might be having some kind of a factor deficiency. And if it is more than equal to 12, the patient has more likely has an inhibitor or lupus. Then we go to the DRVV screen, which is widely used, and it is believed to be specific for LA patients who have a high risk of thrombosis. And it is very robust in detecting lupus anticoagulant. If the screen is positive, then we go ahead with the confirmatory testing. And the confirmatory testing, we again see the normalized ratio. So these are the clotting assays that we use: lupus anticoagulant, DRVV, screen confirm, and APTT mixing study. If it is positive, then repeat testing after 12 weeks is advisable. And solid phase assays, which we do by ELISA, method of ELISA, are anti-beta 2 glycoprotein 1 antibody and anti-cardiolipin antibody. Again, if they are positive, repeat testing after 12 weeks is advised. So the risk of thrombosis based on test positivity. If the LAC or the lupus anticoagulant is coming as positive, then the patient has a higher risk. And then as we go down to anti-beta 2 GP1 IgG and anti-cardiolipin IgG and anti-beta 2 GP1 IgM and then anti-cardiolipin IgG. So LAC, if that is positive, then the patient's risk of having thrombosis is very high. This is the flowchart that we use for our LA profile. So if APTT is normal, then if it is abnormal, then we go to the APTT mixing study. Then again, if the mixing study is showing an abnormality, in that scenario, we go for a DRVV screen. The DRVV screen, if it is normal, then the lupus is absent. If the screening is showing that there is some abnormality and the clotting is taking a longer time than normal, we go to DRVV confirm. The DRVV confirm has a lot more phospholipids than the DRVV screen. So again, we divide the DRVV screen by DRVV confirm, and we find out the normalized ratio. So if the normalized ratio is less than equal to 1.20, then lupus is absent. If it is more than 1.2, then lupus is present. So this chart actually shows that if a patient is triple positive in the first testing, after 12 weeks, the patient is likely to be positive. It's 100% positivity is seen in such scenarios if the patient at the first juncture itself tests positive for all the three lab parameters, and up to 80% positivity is seen on the second time if the patient is double positive, and up to 40% if the patient tested positive only for the single lab parameter. That's why the patient should be tested after 12 weeks for confirmation of lupus. Classification of APS should be avoided. If less than 12 weeks or more than 5 years, separate the positive APL test and the clinical manifestation or the acute condition. VT and D-dimer, almost all patients with acute diseases including DVT or PE, but others as well have elevated D-dimer. And elevated D-dimer is not specific for venous thromboembolism. It can also be increased in malignant growth, RA, intensive care patients, advancing age, inflammation, and pregnancy. And a normal D-dimer means no active clot. So the probability to have a thrombosis is unlikely if the patient has a normal D-dimer. Any elevated D-dimer must lead to further evaluation and investigations. The take-home message is that inherited thrombophilia markers are prevalent in symptomatic population with venous thromboembolism. Isolated arterial thrombus seldom calls for thrombophilia testing, but thrombophilia testing is not routinely recommended in acute thromboembolic episode as it seldom changes the treatment. Exceptions are antithrombin 3 deficiency, as in the patient has heparin resistance, in pediatric age group and in APLAs. Testing is recommended 12 to 24 weeks post venous thromboembolism with a 4-week period free from VKA. Functional assays are a first choice, and lupus anticoagulant antibody tests for APLAs need to be confirmed after 12 weeks. Thank you. There were a few questions, sir, but I think you have already answered to them.
Myself. So one of the questions was in pregnancy, what is the treatment? So even in pregnancy, the routine risk factors may be at play for any arterial ischemic stroke. Even risk factors like diabetes, hypertension, dyslipidemia, all these may be at play. They may have even APLA or homocysteine. So the treatment needs to be individualized, looking at what is the real cause why it has happened, although pregnancy itself is a prothrombotic state.
Right. And I think the next question was how long to stop the medication for doing a thrombophilia test.
So generally in clinical practice, we generally tend to stop it for a week or 10 days, and then we go ahead. So I don't know what is your take on that?
So mostly according to what we follow that the testing should be deferred for at least 4 weeks after stopping anticoagulation. But so I think your perspective actually comes into play over here. Also, is it different for oral anticoagulants and for heparin?
Yeah, so basically for both the things, we tend to follow the safe period of about 2 weeks, because a lot of times, when we are testing it, it's a second test, and uh, we have not still treated the thrombotic episode completely. So we run the risk of the extension of thrombus or something like that. So
Right.
we tend to take a lesser degree of risk. Although, as you said, the accuracy may be higher if we stop it 4 weeks prior.
Right. There are no more questions.
I think there's one question, I believe. What's the ideal time to do a thrombophilia profile? Immediately post-stroke, after 4 to 6 weeks, repeat.
Yes.
Uh,
Yes.
yeah. So, see, the point here is that immediately post-stroke, again, it depends upon what is the type of stroke you're looking at, whether it's an embolic-looking stroke or a non-embolic-looking stroke. And secondly, whether there is any other risk factor. So what is your imaging showing you? So that will determine also to a large extent. And what is the ideal time? So when you're looking at protein C proteinase deficiency in the acute setting, they are likely to be low whenever there's a thrombotic episode. So that probably is not a right time to do the testing. Although you can still take out the sample, and if it is low, you need to definitely reconfirm it. Say after a particular period, maybe around 3 months. So if somebody has got, say, even at that time during the acute thrombotic episode, normal protein C proteinase and all these factors, then definitely there's no question further. But if somebody has got it low, definitely you have to recheck it and confirm the same. But it's not advisable, especially for protein C proteinase antithrombin, to be done in the acute setting of a thrombotic setting. So if possible, it can always be done after 2 or 3 months, and that would count as a first time. And at that time, you have to stop the anticoagulation, do it, and then probably if it's positive, then reconfirm after say 1 or 2 months again. So that would be the right way forward, because the first time when it's low, it can be low in many normal conditions as well, because of the thrombotic state as well.
Thank you, sir. I think there are no more questions. So thank you for taking out your valuable time, sir, for this webinar. And it was very enlightening. And I think that all of our audience also feels the same. And this will be recorded. So this is recorded and it will be archived for the audience. If you want to come back later and watch this, it will be on our YouTube channel of Metropolis.